I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Hello, and welcome to this episode of IDD Health Matters. We have two really interesting guests today that are doing some great work in this field, Wendy Aita and Jennifer Lecomte. Welcome to the show.
Thank you.
Yeah. So I want you to first start off by telling us who you are, what you do, both of you. So Jennifer, you want to go first?
Sure. Okay. So I'm Dr. Jennifer Lecomte. I am a med-peds physician, so I'm double boarded in internal medicine and pediatrics. And I have a primary care practice that serves people with intellectual, developmental, and physical disabilities and their families with embedded behavioral health. So Dr. Aita and I work very closely together.
Yes, and my name's Dr. Wendy Aita. I'm a clinical psychologist. I'm the co-director of the Risen Center, and I'm in charge of behavioral health. So I kind of oversee all of our integrated behavioral health care.
Okay, so where is the practice located?
Our practice is in southern New Jersey, Gloucester County, in Sewell. We're on the campus of a medical school, which is the first medical school on a community college campus. So it's actually pretty interesting there. We have medical students who are upstairs, and we have our clinical office downstairs, so they get the chance to come through and see our practice. And we have an opportunity to employ some individuals with disabilities.
So do you have a focus on any particular group of people?
So how the practice started, actually, when I joined Rowan University and the School of Osteopathic Medicine, there was an exclusive psychiatry program that Dr. Aita was a part of called Mental Health for Intellectually Disabled. Unfortunately, because of the payment models, the grant had gone away and those patients were losing access. So a large way that we started was incorporating people with dual diagnosis, so those with intellectual disability and mental health concerns. What we found that we were lacking was a platform for primary care and making sure that they had access to routine preventative health care, and that's where we embedded behavioral health in our primary care practice.
So I'm glad you said, when you said dual diagnosis, you explained it, because sometimes in this field we hear dual diagnosis, and that means a person with a mental health condition and a substance use disorder. But here we're specifically talking about a person with an intellectual disability and a mental health condition, right?
Exactly that.
Yes. And that can be pretty challenging sometimes to figure out what's going on, what's mental health, what's medical. So I love this team approach, and it's something that's so important. I talk about that a lot. You really need the integrative approach. So describe to us, and Wendy, I'll let you go first. Describe to us what this collaboration looks like when you're seeing a patient.
So all of our patients actually get 3 touches. They first come and establish primary care, because we know that access to healthcare and good primary care as your medical home is very important. And oftentimes behavioral challenges are related to pain, gastrointestinal problems, dental problems, other aspects that are not mental health concerns. Then we have a second touch with our social workers who provide community coordination and care and assess caregiver burden so that we can care for the caregivers. The third touch is with me, and I do a psychodiagnostic evaluation. I assess kind of baseline, because sometimes they don't need any mental health services, and I want to know kind of where they are in case they do come back. If there is a need for mental health services, we have a psychiatric provider and we do counseling. I assess for trauma, and then I assess for their ability to access routine medical procedures, because we do a full desensitization, anxiety reduction, trauma treatment for access to routine medical procedures.
So an extension of that, and what we really found is the disparities for our patients in accessing routine preventative care that's as basic as getting weighed, having accessibility. So we have ceiling lifts in every one of our primary care suites and our specialty care suites. So when we were able to open this building, we were able to design it with that in mind. So every one of our suites has a ceiling lift that can weigh. We also have wheelchair scales, so a weight it seems so basic, but access to a weight was really an important part of
I was going to say
design.
that it's one of the basic things. You're talking about preventive care, and then you mentioned weight. I'm like, that's not even preventive care. That's just something we should have the ability to weigh everyone in our clinic.
Every single one. So my experience before we were able to design our own practice, I had to send some of my patients to the YMCA. They didn't even belong there, but that's the only place that I could get an accurate weight. And it's from both sides of the spectrum, both underweight and overweight. But certainly we know that people with complex medical conditions that originate in childhood really do have weight as a huge impact. The medications that we prescribe affect it in both ways. So our most recent opportunity that we got through a grant through the IHC and Developmental Disability Services in New Jersey is for access to women's health. Sexuality and disability, if you put those two things together, people will just not access routine preventative care. So reproductive health exams, breast cancer screenings, mammograms, cervical cancer screenings, and just the ability to develop human relationships, intimate relationships when you have a disability. And then beyond that, being able to have a family. So opening up that dialogue. Right now, we're working with women with intellectual disabilities, but when we did our focus groups, we found that families were really asking this for everyone. So we know we have to expand that, but that's where we're starting.
Well, preventive care we know is an unmet need of many people with intellectual and developmental disabilities. There are lower rates of screening for all of the things you mentioned, and prostate cancer as well too, and oral health screenings, which contributes to some of the challenges that we face and delayed diagnosis. And I think sometimes there might be some physical barriers. It might be difficult to get a mammogram on a person in a wheelchair, and those are things we need to address. Just being able to get a weight, like you said, is one of those physical barriers, or being able to get onto an examination table for an exam. But sometimes the barriers, I think, probably relate to the perception that clinicians have sometimes of people with disabilities that, well, maybe they don't really need these screenings because they don't have a good quality of life.
That's actually absolutely the barriers. We did a survey, and the barriers, and quite frankly, I just find it with some of my specialty colleagues that a criteria for a PAP exam is if you're sexually active. It's not in any of our health literature that being sexually active is the reason that you do the healthcare screening. But then there's also their parents and their caregivers' biases that they equally don't need to have these screenings because they're not in physical, intimate relationships with folks. And the diagnostic overshadowing that their disability is what we have to worry about right now. The unfortunate part is that many of patients with intellectual and developmental disability are dying earlier than they need to because of preventative health and the poor access to it.
Dying earlier is certainly one thing, and the other part of it is suffering unnecessarily because they were not diagnosed or misdiagnosed. And when we talk about diagnostic overshadowing, and we've talked about it here in this program before, but just to remind everyone, that's where the overall diagnosis of the person's disability is looked at as pretty much the cause of everything. So if there's a new behavior or there's a new symptom of something, they're doing this just because they have a disability, and they're missing diagnoses of what actually might, they won't even look further to look and see what actually might be causing this change. And many times it's a treatable underlying health condition. So it's great that you're addressing all of that as well too. You said something about the caregivers and paying attention to the caregivers as well. Mm-hmm. That's an often overlooked aspect of this because, let's face it, it can be challenging to provide supports for someone, no matter how much you love them, on a 24/7 basis. And it sounds like you make sure that the caregivers have access to services as well, too. Talk about that, please.
Yeah, absolutely. So every family that comes in, we do a caregiver burden inventory, and assess kind of where their challenges are falling. Sometimes it's really just getting the individual, their child or adult, access to the community and being involved, and that decreases their caregiver stress. But we also take care of the caregiver's medical needs. So patients who come in, we care for their caregiver because sometimes mom has put off her preventative health exams.
Yes, that's actually what we really found, is that because you're having to travel farther to get access to care, and we don't want to be the service provider in the tertiary care area or in the Tri-County area, because we really want people to receive care in their own medical neighborhood. But we recognize that if people are accessing care farther away than in their medical neighborhood, then mom needs access to her flu shot too. During the pandemic, we were equally able to provide the direct service providers with their vaccine at the same time. You did not have to be a patient in our practice in order to access that, because we needed our patients and the community around them to be safe and healthy so that we can get through the pandemic. And we know all the other access points were so challenging for our patients that if we put up another barrier for their caregivers not to get care, then they would unfortunately suffer even more. And we definitely found access to just their fun activities was such a barrier and such a burden that we at least needed to make sure that healthcare wasn't that barrier too.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, "My ability is stronger than my disability." We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
I'm Dr. Craig Escude, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. So, in thinking about the type of practice that you have, this is, again, I see this as a model. I mean, I've been talking about how important it is for integrative care, meaning, integrative care can mean a lot of things. Right here, we're really talking about primary medical care services and being integrated with behavioral health services as well. And our minds are certainly connected to our bodies, and our bodies affect our mind. And when things are not going well in our bodies, it can cause us to be upset or stressed or worried or anxious or depressed. And when we're stressed or anxious or worried or depressed, it can cause other things to happen in our bodies as well. So this is the model for everyone. We all should have this. But I've always said it's exceedingly important for people with intellectual and developmental disabilities, because so many times, especially in people who don't use words to communicate, they communicate through different ways, usually some sort of behavior that we call, they say aggressive behavior or challenging behavior. And again, back to that diagnostic overshadowing piece. Oh, it's just because I have IDD. But it could be a medical condition or a mental health condition or both of those things. And having that integrative approach is so valuable and important. So I think it's wonderful what you're doing. Now, are you sharing this with other clinics? Are you going to just take this everywhere?
So we definitely want to. So we have a couple partnerships that we're trying to get it out further. So we've been working with Autism New Jersey, and we're now creating a healthcare consortium in order to do that. I think coming to conferences like AADND, where knowledge is shared very readily, models are shared very readily, very different from, some of our other academic partners where it's a little bit more held closer to our cuff and not sharing it as much. I think that we still have opportunities to not work in silos. I think that there are a lot of models like this that are out there. Unfortunately, I don't know where to find it. And I think that programs like this to help us get it out. I appreciate podcasts like this that get people like-minded to share more information. I definitely think that we need like a registry or some other format where we can share information more readily so that we can get some good data on our outcomes. We can tell you anecdotally, and we are trying to collect more data, that our patients are getting better access. We've had several patients come to us who've required sedation for vaccines. Just a vaccine, or for blood draws, or definitely for women's health, or for dental. And so some people think that because it might be a higher surgical need or a higher priority, that sedation should be our first option for providing access. And when we embed behavioral health and do desensitization, or quite frankly, just give time and space and give time to learn about how people need to receive care, it doesn't even take more than one session in order to get that access. But sometimes in our medical field, we have caused trauma for our patients and for their families. It's not just about the patient trauma, but also about the family trauma. And when we address that, we've opened up access to our patients' needs to get outside of our office.
So I want to come to you to talk more about trauma and trauma-informed care. And maybe can you tell us more about that concept and what it means?
Yes, certainly. So trauma-informed care is having a practice that understands that everyone has experienced some sort of trauma. When we look at childhood experiences of trauma, and they are cumulative, you look at individuals with intellectual disabilities, they will often tell you that they have been mistreated. They're at a higher rate of having significant trauma, sexual trauma, verbal trauma, and having 10 times the rate of trauma than the neurotypical population. So when somebody comes into our practice, we have to think, what has happened to you before we even talk to them? Because we have to go in with an understanding that there is trauma already there that they might not be able to tell us, or they might not be able to put into words. So we have to have our practice situated in a way that we expect that trauma has happened, and we are careful to ask permission before we touch them, that we talk to them directly rather than talking to their caregiver, that we treat the trauma before we try to do any type of these invasive, whether it be lab draws or PAP exams, that we talk to their caregivers and we treat the trauma of the caregiver too, because sometimes somebody walks in and it's mom's anxiety that is so high from having seen it happen in the past, seen an explosion of behavior, or having watched their child being held down, that, we often think that individuals with autism do not understand emotions. What I find is they are exquisitely attuned to their emotions of their family members. And so if mom's anxious, the individual is anxious too, the patient's anxious. So we have to decrease mom's anxiety in order to be able to improve access too.
Yeah. Do you have anything to add on that?
Well, I think she hit it very well. I think a lot of the parallels I relate back to our geriatric population too, in caring for the caregiver. So I think we already have some good data and models out there that we haven't necessarily brought into parallels, at least can get us started with some of the data and then relate it back. So I think we have some opportunities to look at that in the geriatric population too, and certainly after a lifetime of experiencing healthcare, or for some of our patients, anyone can enter into the disability population at any point in their lifetime. Us sitting right here tomorrow, any one of us can enter into it. So that's why this shouldn't take a special doctor to take care of it. That anyone is going to enter into your practice at any point and may enter into the disability community. And they're going to want people who know how to take care of them.
So do you have a particular success story that you might be able to share with us?
Yes, certainly. So Dr. Lecomte already mentioned we had a patient who was unable to go back to school because he could not get his injections for vaccines. And Dr. Lecomte had worked very hard to get him to be able to even inject himself, to use a little bit of a sedative beforehand. And ultimately, he had to go under general anesthesia to get his injections and to be able to go back to school. So fast forward to COVID time. Now we need to get a COVID vaccine. And so I worked with him with actually a specialized technique called EMDR, eye movement desensitization and reprocessing, because he had a trauma when he was 3 years old and he had been held down and they had drug him out from underneath of, there had been a bed that he went to hide under, and multiple people had to come in and hold him down in order to get blood draw for him. And he recalled that very, very vividly. So we did, I believe it was 6 sessions of EMDR, and he was ready to get his shot. He got his first vaccine in my office without any sedation or anything else.
So I guarantee you people are going to want to know what EMDR is. Can you explain that pretty quickly?
Yeah, eye movement desensitization and reprocessing is a form of trauma treatment that is used oftentimes in veterans to treat PTSD. And the way it works is it assumes that somebody has had a traumatic experience that has been encoded and stored improperly within their brain and related to a very fearful and intense emotional experience. So the idea is to have the person think about the experience, and they literally watch your fingers and move their eyes so that we can kind of untangle the processing that has happened that is showing that very high fear response and startle response. And it's been very, very intensely studied within the veteran population, not so much in the autistic population. And this young man has autism.
And it worked.
It worked. It worked amazingly. Yes.
Yeah. And so that, it didn't work just one time. So that's the beauty of when we start to have patients tell us how they need to receive care. Once we know how to do it, then they can have access to multiple avenues of healthcare. So routine preventative care. When they get sick, they're less anxious about coming in. Certainly, telemedicine has helped. It also allows us to enter into the homes of some of our patients so that we can recognize maybe some other opportunities where we can help them. And I think that I don't even think we know how to begin to study that when we can recognize their own environment and how we can impact care there too. Because oftentimes we're having patients meet doctors for their needs, not the reverse. So I think being able to enter into their homes now through telemedicine, and I certainly hope that we continue to be able to use that as a resource for our patients, because it's definitely opened up some doors. We still want to see patients in our office. We still know that our personal relationships with our patients really matter. It worries me because, our current generation of accessing healthcare wants it yesterday. And I think that relationships still matter. And I don't think it's just if you have an intellectual disability. I think we all really need to grow and develop and develop relationships, both with our healthcare providers and otherwise. So what we're hoping is that we can get people access to preventative care so they maintain health, so that they can be in the community and really grow there.
Living their best life.
It's absolutely beautiful. Living the life they love, which is something we all want to do, right? So one of the things I like to do, I call it 3 and 3. So 3 things in 3 minutes that you would like to share with everyone that you think can improve health, wellness, the general life of people with intellectual and developmental disabilities. Really just any 3 words of wisdom that you have. So would you like to go first?
Sure.
Okay.
So I will tackle it from the psychological perspective. May is Mental Health Awareness Month for the United States. And one thing that we often don't realize is there are very simple things that we can do for our own wellness. And there was an article that came out through the American Psychologist just this week that indicated that 3 things that anyone can do to decrease psychiatric illnesses, right? And those 3 things were exercise. And it doesn't need to be intense exercise. We know for individuals with autism, 10 minutes can decrease any anxiety and increase their chances for emotional regulations for 60 minutes afterwards. Doesn't need to be much, right? The second thing is being in nature. And the third thing was yoga. So those 3 things, significantly through a systematic study of all the studies, found decreases in psychiatric illnesses.
Wow, that's impressive.
So I would actually extend to that. So I was going to say we're working on really what is medicine, and food is medicine, mindfulness is medicine, art is medicine, access is medicine, and medicine is medicine. And so I think that we're really trying to figure out how do we get people to bring their lives into our world, and we really get to know them so that we can make recommendations that are beyond taking another pill, and certainly looking at maybe scaling back how much medicine we're using and get back to nature, yoga, exercise, things like that.
Well, I think I'm going to go exercise shortly after this, but I really want to thank you both for being here. This is, I love what you've shared with me and with us. The model that you have is wonderful. It certainly needs to be expanded out there. For any of you that are clinicians out there and want to learn more about what they do, where can they find you guys?
Sure. So we have a website, risencenter.org, I believe. But anyway, we're on the Rowan Virtual School of Osteopathic Medicine clinical site. So Risen Center in Sewell, New Jersey.
And we do have an email, which is risen, RISN, at rowan.edu. And Rowan is ROWAN.
Wonderful. Doctors Wendy and Jennifer, thank you so much for being with me today, taking the time to do this, and also for the work that you do in this field.
Thank you. Thanks for having us.